Good evening, everyone. I am Dr. Avishekh. I'll be taking class on shock part 2, and this is going to be some part will. I mean, there will be a majority of repetition of the first class because in the last class I took an extensive class on shock as a whole, and I covered a lot of topics including hemorrhagic shock, cardiogenic shock, septic shock, guidelines, and lot more things like fluid responsiveness and all. So I was not quite aware at that time that I had a second class. So I would like to focus in this class on few of the intricate topics which are not so commonly discussed. So kind of it will be a revisit to important aspects which were not discussed yesterday. So the again, so I'll not go to the section of hypovolemic or hemorrhagic shock. This one I'll skip. Shock definition, hypovolemic shock, I have already completed. I'll not go to them. If anyone has any queries, they can raise right now. They can ask in the chat box if they want. So I'll directly go to the section of assessment of shock. So this I will again go through quickly so that we get a comprehensive review as to how you approach a shock patient. So yes, last time also I have covered this. This time we'll go to a bit extent and as I said, discuss about the important things. So while we're assessing a patient of shock, if we are not sure about the type of shock, we want to look at the major things like the pump, the tanks, and the pipes. So that's usually how we remember. Pump means heart. The tanks are the vessels, the reservoirs, that's the venous system. So, and the pipes are the major other vessels like the deep veins, the arteries, etc., and the aorta. So, if you want to look for a cause of shock, you want to look at the pump. So, you look at the heart and its contractility, whether it's reduced, so it's a cardiogenic shock. If it is normal or slightly increased, it could be hypovolemic or septic shock. Then again, you want to look at the pipes. The pipes are mostly the IVC, inferior vena cava, superior vena cava. So if they're collapsing, if their variation of the diameters is much more, indicates that the patients are mostly fluid responsive. There is a component of hypovolemia. If they're distended, it could be cardiogenic shock or a resolving phase of a hypovolemic or septic shock. And then you look at the art pipes. That's the the deep veins. If you have a DVT, that could be a reason that you should think that pulmonary embolism could be a possibility. If you have an aorta, if you look at the aorta by means of transesophageal echo in an emergency care or an ICU, and you find out that there is an aortic dissection, then your cause of shock is also found out. So we have to have a framework in mind how to approach the patient, and there are different protocols for that. This is the previous day's PPT only, so I'll just go into that details. But if you people have known about do you know about rush protocol? If people have heard about rush protocol. So what is rush protocol? Rush protocol is when you want to look at the different causes of shock. RUSH stands for RUSH stands for rapid assessment of ultrasound guided assessment of shock and hypotension. So that's rapid ultrasound guided assessment of shock and hypotension. So you need to use your ultrasound in regular practice, and by using the ultrasound, within 5 minutes you will get to know what is the underlying etiology. So the first thing to rule out in a case of a shock, unknown shock, is to rule out obstructive shock. So you take your ultrasound probe and you put on the parasternal short axis view, this we call it. So here we put it and we look at the pulmonary arteries. This is actually long axis view with enlarged RARV, but you can also put on the short axis view and look at the pulmonary arteries. Meaning to say that in the apical fourth chamber, this you see that on the left side, this is actually RV, this one is RV, this one is RA. This was in LV and LA. So RARV is kind of dilated as compared to LA. And in an acute setting, this can occur in pulmonary hypertension, acute pulmonary hypertension. And the most common cause of an acute pulmonary hypertension would be a pulmonary thromboembolism. So this is the case of pulmonary thromboembolism. Similarly, if you look at the lungs and if you feel that there is no, there is no absence of lung sliding, then it indicates pneumothorax. This is not there in this PPT, but if you have to look at the lungs and you have to look at the LVOT and the pericardium. LVOT obstruction, I will again focus later upon how to diagnose and all. So pericardium, if we look at the pericardium and we find that there is a chink of fluid around the heart, so that could be underlying, that indicates there is an effusion. and what indicates that the effusion is actually going for tamponade. Now, these are the few added points that I'd like to discuss today. So, what indicates that the pericardial effusion is actually a tamponade? So, there are few features like if you have a dilated IVC, if you have a collapse of the right atrial free wall and the collapse of the right ventricular free wall. Now, it depends on the cardiac cycle. The RA collapse can occur anytime, but more specifically during systole and during diastole if you have an RV collapse. These are the signs which indicate there is a pericardial tamponade. And the other findings could be that in a spontaneously breathing patients, if you measure the pulse wave Doppler velocities across the mitral and the tricuspid valve, you can find that there is around a 25 to 30% difference in the velocities. Although this is not so specific, and this is only found in spontaneously breathing patients. But if you find that there is a pericardial effusion and there is an RA wall collapse, there is a collapse of the RA wall, always think about pericardial tamponade. There are multiple other etiologies which can also mimic a pericardial tamponade. You can have something known as a low pressure tamponade. So pericardial tamponade on the initial beginning period don't have hypotension. Always remember this, that pericardial tamponade initially have tachycardia and hypertension to begin with. And if you don't do an ultrasound at this phase, you miss out on that and you give a hypotensive agent, the patient will crash within 30 minutes. So it is very important to do the ultrasound in routine practice. And the initial sympathetic surge is what makes the patient alive, keeps the patient alive. So do not go for anything, any hypotensive measures at that period. If you identify that, immediately call the cath lab and do a pericardiocentesis. Similarly, pulmonary thromboembolism, if you find out, you will obviously call the cath lab, you will involve a cardiologist. Depending on the severity, either you go for thrombolysis or you go for a PA directed measure, PA catheter guided measures like a mechanical thrombectomy or a catheter directed thrombolysis. Different modalities will be there. Management as a whole, it's a totally different topic together. I'm not going to the details. And LVOT obstruction I'll be discussing today again. So this is one of the overview of how we'll look at the shock. So if you look at this picture, you will get to know that this picture on the left side is looking like a normal heart. So this is an apical 4-chamber view. You see 4 chambers. This is the LV, which is having a cylindrical shape along with a muscular wall. Behind the LV is the LA, and the right layer just adjacent to the LV, this triangular structure is the RV, and backside is the RA. And in between the valves are the tricuspid here and the mitral valve here. If you just tilt it, you will also see the aorta here. So you can get a apical 5-chamber view, and you can measure something known as a VTI. VTI I have discussed in the last class. On the right hand side, if you look at this image, this is obviously a global dilatation of the chambers. This is not a live image, but we can make out, okay, the LV, LA, RA, RV, everything is dilated. So probably this is the cardiogenic shock. For VTI measurement, we have to take the apical 4-chamber, tilt your probe towards the patient's head end and get an apical 5-chamber. Here, you have to put the Doppler at the LVOT. If you imagine anatomically, the LV is opening through the LVOT and emptying into the aorta. This will be in between the RA and the LA. So this is opening up only in the apical 5-chamber view. And once you put the pulse wave or the continuous wave Doppler, you get a triangular shaped velocities. And then there is a software which gives you the software is inbuilt. You just have to trace the velocities over time and you get a VTI. The VTI is a volume time integral. So supposedly there is one RVC at a particular time which moves with a particular velocity, say suppose x. Another RBC moves at the different velocities of say y. So if you combine all the velocities and integrate it over time, you get a velocity time integral. What does it mean? It means that how much amount of RBC or how much amount of distance does an RBC cover after one pump of the heart. So if the heart pumps one time, how much distance does one RBC molecule cover? That's exactly what gives you it gives you a kind of a distance that is covered by the RBCs. And if you get the area of the LVOT, then you get the area into the distance. So if you multiply area into distance, you get the volume. So that will give you the exact cardiac output. These are all bit of approximations are there. These are not sacrosanct and exactly accurate, but this gives you a fair idea about the cause of the shock. Now supposedly in a patient who has a normal heart, who is having a normal looking cardiac chambers, and you find the VTI. Now in one patient you see the VTI is 8, which is low. Normal value is 18 to 24. In another patient, you see that the patient VTI is 26. So what is the difference? So in the formal one, the VTI is low. That means despite the heart functioning well, the volume or the distance by which the RBC is getting transported is less. That means actually the volume is less. So means this is a hypovolemic shock. But if at the same time, if your VTI is normal, that indicates it is a septic shock. However, if your cardiac function is abnormal, heart is dilated, and the VTI is small, that means it is a cardiogenic shock. I'll again repeat. So, if you have a normal size heart, normal VTI, that means it's most likely a septic shock or distributive shock. If you have a normal functioning heart, ejection fraction is good LV pump function, but VTI is low, that means it's hypovolemic shock. And if you have a dilated heart with a low VTI, that means it's a cardiogenic shock. Similarly, if you look at the VTI, that will give you the idea about the forward flows. If you look at the IVC, that will give you idea about the backward flow. What is the function of the diastolic function? How much pressures are there in the systemic veins? So if you look at the IVC, if the IVC is collapsing, chink, variability is lot more, that means there is a bit of fluid deficit is there. Probably it is there. But if the IVC is kind of dilated stem type, it's completely filled, called as the plethoric IVC, it means the patient is volume repleted or volume distended, overloaded volume. Could be cardiogenic shock, could be resolving phase of septic shock where you have given plenty of fluids, or it could be an obstructive shock. Like if patients with cardiac tamponade, you will find that severe cases you will have distended IVCs. So this is like an example of a collapsing IVC where you see that the IVC's maximum and minimum diameter is varying quite much. The formula for IVC collapsibility is maximum minus minimum by maximum. But to be very frank, on a regular basis, we don't measure it. We just simply put the ultrasound and see if the IVC is collapsing, distending, what is the variability. If the variability is not there, patient is not going to be fluid responsive. So these are the traditional way of looking at the patient with shock without the if you don't have an ultrasound. What you can do is measure the cardiac output. The question comes, how will you measure the cardiac output? So in these cases, traditionally PAC, pulmonary arterial catheter, was introduced. So before the say 2010 era, intensivists used a lot of PACs in shock patients and ICU patients, but later on it kind of went out of vogue. The reason being that PACs are a bit invasive, it can cause complications on its own. Plus, there is a lot of approximation that takes place. So if you put a PAC onto the right heart and you are actually trying to measure the left heart pressure, there is a lot of approximation. And that's why during shock management, PAC has gone out of vogue. Still, if someone wants to know how to measure with a PAC, PAC gives you an idea about the cardiac output, and it will tell you about the few static parameters like the central venous pressure and the pulmonary capillary wedge pressure. So if your cardiac output is low, that means it's either hypovolemic or a cardiogenic shock. If your cardiac output is normal or high, it could be a septic distributive shock. So it's mostly a distributive shock. Similarly, if your cardiac output is low, it could be either a hypovolemic shock or a cardiogenic shock. So now look at the CVP or the PCWP. If your CVP, PCWP, the cardiac filling pressures are more, that means it's most likely a cardiogenic shock. Again, these are not dictums. Sometimes if the patient is dialyzed or patient is receiving too much diuretics, their cardiac filling pressure will be normal only, despite the fact that the ejection fraction is low. So let us not take it to an extent that, okay, every cardiogenic shock will have raised PCWP or CVP. But most likely, if we want to look at the patient at time 0 without having any other inclination, if your CVP, PCWP is high and your cardiac output is low, it's a cardiogenic shock. And if your cardiac output is low, and it could be, as I said, if the cardiac function is normal, then it could be a septic shock or a hypovolemic shock. So in that case, if it is hypovolemic shock, your CVP is bound to be low, then you give more fluids. And if it is cardiogenic shock, you have to treat the cause with the tropic support and then find the cause, probably go for mechanical circulatory support. And then again, if it is an obstructive shock, then you have to treat the obstruction. As I said, the discussion about on the management of pulmonary embolism, cardiac tamponade, etc. So if you don't have all these measures, you can put a simple arterial line, look at the blood pressure and its trend. Pulse pressure volume is one measure of dynamic fluid responsiveness. I've already mentioned in the previous class. The tests of fluid responsiveness is one of the major tests that we take. So if your pulse pressure variation is more than 15%, so generally the range is 12 to 13%, but if it is more than 13 to 15%, it indicates there is a component of hypovolemia. But there are a lot of approximations in these cases. So in these cases, we cannot actually use, I mean, there are a lot of approximation in ICU patients. So we have to go through the checklist of applying this pulse pressure variation in ICU patients. If you don't have this, you look at the patient's neck, you look at the JVP, you look at the patient has pulmonary, pedal edema or not, and then you look at the patient's acuteness of deterioration. Whether it's an acute onset hypotension, hypoxia, that could indicate that it's a pulmonary embolism kind of physiology, or it's a chronic thing which can indicate something else. So I will ask you one thing. I will expect some volunteers to answer. Supposedly there is a scenario that a patient is there who is ARDS, say 80 upon 40, and so you have to increase the vasopressor. So my question is for fluid responsiveness. How will you check for responsiveness in this patient? Prone ventilation, ARDS, first station of proning going on, hypotension. Anyone to volunteer? Any test that anyone can name about? In last class we have discussed about the fluid responsiveness, different parameters. What test can you apply here?
Straight leg test.
Okay, now just imagine a patient having a prone position. How will you perform the leg test? You cannot
Acha,
do the.
okay.
Okay, so you have to apply your, if yes, one person has rightly pointed out. Any other answers that we can think about? What is the problem with pulse pressure variation in these cases? Supposedly patient is prone. What is the problem? So first of all, the problem is that first of all, for the PPV to measure, you need to have a pulse pressure variation that will be shown on the monitor. Monitor should have that algorithm. Second, you need to have a proper cardiac output assessment device. So you'll have to apply a cardiac output monitor to every patient to measure the the pulse pressure, the cardiac output. So that determination of the whether the patient is fluid responsive or not, and exactly say how much of fluid to be given. So pulse pressure variation, it's a proper monitor. Probably better to be guided with a cardiac output monitor. But the major thing is that you need to have 8 mmol per kg of tidal volume. That is applicable to every test that is based on heart-lung interaction. So pulse pressure variation, stroke volume variation, and IVC distensibility, these all have the same problem. Is that you need, it is dependent on the pulse pressure variation. So if we have discussed in the last class also, I'll just go to that quickly and tell you. Okay, so the problem is that it will all, yes, this one is the most important thing. If the patient is having anything among spontaneous breathing patient, cardiac arrhythmias, or ARDS with low tidal volume, you cannot do this test, pulse pressure variation, stroke volume variation, anything that based on the heart lung interaction. So you can do a passive leg raise, but I've already told patient is prone, ARDS, paralyzed, you cannot do passive leg raise. And obviously you will not make the patient supine just to take a passive leg raise. What you can do is end expiratory occlusion test and mini fluid challenge test. So mini fluid challenge test, how it is done? It is generally 4 mils per kg is given, 250 to 300 ml, tap over 5 to 10 minutes and check after 10 to 15 minutes. But you need to have a cardiac output measurement device. If you don't have that, you can just corroborate with your pulse pressure variation. If your pulse pressure at the beginning is, say, suppose 16%, and after giving the fluid, if it is reducing, then probably you can say, okay, we can give some fluids. But again, pulse pressure variation could be falsely low in these patients. So you cannot really justify your fluid responsiveness based on pulse pressure at all. What else can be done? End expiratory occlusion, okay, it can be done. Good test. You just simply occlude the tube and wait for 15 seconds and measure the cardiac output. If it is increasing by beyond, there is limit is there. End inspiratory, exit expiratory, multiple things can be done. But if your end expiratory is more than 5%, it is positive for fluid responsiveness. Again, you need to have a cardiac output monitored in situ. You always don't get that. One person has rightly pointed out tidal volume challenge test. Okay. So what is tidal volume challenge test? How is it done? And what is the how it is done? So I'll just quickly find out. Yeah. So tidal volume challenge test is a test which is done. Uh, let me find out. It is there. Okay, ARDS updates I have included. So I'll just go up. I mean, tell along with I'll find the slide. So tidal volume challenge test. Yeah, this one. So tidal volume challenge test is a test where you basically increase the patient's tidal ventilation from 6 to 8 ml per kg. So patient is now ventilated using a lung protective ventilation 6 ml per kg. So what you do is increase the tidal volume to more than to 8 ml per kg. And 6 to 8 obviously will increase the transthoracic pressure and it will have an impact on the heart lung interaction. If the patient is volume depleted, the pulse pressure variation will increase. The difference of pulse pressure variation after changing from 6 to 8 ml per kg, if it is more than 3.5%, if the SVV is more than 2.5%, it has an area under the curve of 0.99, means it has a very good accuracy or sensitivity specificity to diagnose patient with fluid responsiveness. So if one word answer, patient with ARDS, how to check fluid responsiveness, tidal volume challenge test is a good answer. What else can be done? Now this is today's class's importance is obviously IV separation, mini fluid challenge test, but again mini fluid you give in an ARDS patient 300 ml tidal positive pressure, positive for balance also is detrimental. So don't go for that. What else can you do is do a PEEP challenge. PEEP challenge test. So the if you have known about the tidal volume challenge test, the PEEP challenge is the same mechanism. You just increase the PEEP, your intrathoracic pressure increases, and that will lead to a reduction in the preload cardiac output, and you have a increase in the pulse pressure variation. So, and but again with the PEEP challenge test, it is actually standardized based on cardiac output. So you need to have a cardiac output monitored as a better measure. So you increase the PEEP from 5 to 10 or you decrease from 10 to 5. Either ways, if you have an increase in cardiac output by 8 to 10% after reduction in PEEP, you call it fluid responsive. So in ARDS, we tend to give higher PEEP. So if you temporarily reduce the 10 to 5 and note the pulse pressure variation change or the cardiac output increase after 1 minute of the change. So if you change now, after 1 minute you check the cardiac output, if it is increased by 10%, it has an AUR of say 0.94, a moderate sensitivity or specificity of using it. So PEEP challenge test is today's additional test that I just told about. So we have to be smart enough to answer these questions. So tidal volume challenge test, end expiratory occlusion, and PEEP challenge. PEEP challenge is not seldom used, so I would advise that you use it before answering in an exam. But tidal volume challenge test and end expiratory occlusion test are mandatory for this kind of scenarios. Okay, where you cannot use your other tests like PPVs and all. Another theoretically asking question, a conceptual question to open audience. Supposedly, a patient is spontaneously breathing, and patient is having a respiratory rate of say 25, hyperventilation, and you are now checking the pulse pressure variation, and whether first of all whether you should check pulse pressure variation in this case. Second question is that if at all you check, how will you interpret it? Any volunteers? Spontaneously breathing patient, tachypneic, respiratory rate of 25 to 26. Would you do the pulse pressure variation in this case?
No.
It's a good answer. No. But if I say that you can do. So basically, what is the problem in doing a pulse pressure variation in these cases is that you get a lot of false positives because there is an increase, I mean, huge fluctuations in the intrathoracic pressure. You get a lot of false positive value. Even a pulse pressure variation of 25 may be normal. In these cases, your sensitivity actually reduces. What you have to look at is that you have to increase the cutoff. This much now, the studies are scarce in these cases. There is not much amount of data, but you can actually do a pulse pressure variation. And if the cutoffs are say PPV of say 40%, patient is probably fluid responsive, even if spontaneously breathing patient. So meaning to say, we have to understand the test individually and apply them in our practice. You are right in saying that PPV should not be used in this case. At the same time, if at all you don't have anything else and your PPV is huge, it probably indicates a hypovolemia some sort. Again, again, let me frame you something. Same patient, spontaneous breathing, pulse pressure variation of 40%, distended neck veins, muffled heart sounds, and patient looks extremely toxic, like as if patient is going to collapse. BP is on the lower side, say 90 by 40, 90 by 50 BP, muffled heart sound, distended neck veins. But pulse pressure variation is huge, 40% pulse pressure variation. So any ideas about what is causing it?
Pulmonary embolism.
Almost, you're almost there, almost a close mimicker. What could be else? So this is actually a cardiac tamponade. So anything like a cardiac tamponade or a severe COPD exacerbation, these cases will cause depends a lot on the interventricular dependence. So if you have an increase in the right-sided pressures, obviously the septum goes towards the left side and impedes the left ventricular outflow, causing hypotension. You know about the cardiac tamponade physiology as a whole. All these things, what it does is also increases the pulse pressure variation. The simple pulsus paradoxus. What is pulsus paradoxus? It's the augmentation of normal increase in the pulse pressure that we see in cardiac tamponade patients. They're not hypovolemic. So again, the next thing to remember is that these tests also depend on the RV-LV interdependence. And in cardiac tamponade, severe COPD exacerbations, this can be falsely positive. So again, I'm saying don't just based on one test give fluid to the patient or decide on what to give. Use your multiple tests. Do an IVC ultrasound, do an echo, do a capillary refill time, and then obviously do the passive leg rest PPB. All these things you have to combine and then decide upon giving fluid or not. So same thing happens if you have a patient with ectopics. Just go to an ICU and see any patient who is having multiple ectopics. You see, whenever the ectopic comes, the pulse pressure reduces drastically. Whenever the next normal beat comes, it increases drastically. So that during that period of ectopics, you will have a lot of pulse pressure variation. And a patient who is having, say, bigeminy, ventricular bigeminy, atrial bigeminy, you will have a lot of variation in the pulse pressure. And that's why you have to remember the chart which I showed previously. If you have a spontaneous breathing patient, if you have a arrhythmias, especially RV pathophysiology and ARDS, you have to use this test with caution. Similarly, uh, supposedly you are working in an ICU and you are having a patient with pancreatitis. After 1 week has passed, patient has come and now it is in your ICU. Patient has raised amylase lipase to begin with. Abdomen is distended, bit tense. He has localized collection of fluids. So it's necrotizing pancreatitis with localized collection. A modified CT severity score of say 8 upon 10. So that's a severe acute pancreatitis. Has AKI, ARDS, not ARDS, acute lung injury, subpleural effusion. Patient is now in shock. So your colleague wants to use an ultrasound measure to determine whether you will give the fluid or not. What can we use? So patient 7 week into after acute pancreatitis diagnosis in ICU, in shock, and you want to test whether the patient is fluid responsive or not. How will you test? So what could be your test of fluid responsiveness here? Can you use a tidal volume challenge test here? Answer is no, because patient has to be intubated on the first thing. Patient, if it is not intubated, then obviously tidal volume challenge test, end expiratory occlusion test, this test won't be applicable only. So what else can we do in this case? So one option is, can we do a PLR here? You can do a passive leg rest test here, simple passive leg rest test. Can we do a pulse simple fluid challenge, small 300 200 ml? Can be done. It is acceptable. Okay, you give a 300 ml fluid bolus. If you have a cardiac output monitor, you can just look at it, or you have a pulse pressure variation, outline in situ, you can have an idea. You do the routine echo. What test not to be done? Can we use an IVC ultrasound here? You cannot use an IVC ultrasound because the abdomen is distended. There is an ascites that is pressing on the IVC, and the IVC is going to be collapsing. And this is a major mistake that many people do. So do not go for IVC ultrasound if you have an intra-abdominal thing, intra-abdominal ascites, acute intestinal obstruction, whatever the etiology. Do not go for IVC. So that's why doing a POCUS is important. By knowing how to use it, where to use it, and knowing the drawbacks is very important. A falsely misinterpreted POCUS can land up you in problems. Supposedly you look at the IVC, okay, it is collapsing 8 millimeters, you give a lot of fluid, patient goes into ARDS and pulmonary edema, patient dies. So this can happen. So don't rely on, so do these tests judiciously and always keep in mind what test can you not use in these specific scenarios. So if you look at the, again to just revisit the thing, if you have a patient with ARDS, and what are the, how will you just ascertain whether you can give fluid or not? So one of the tests is having a pulse pressure variation, but again pulse pressure variation is falsely low. You can you have a ratio of pulse pressure variation into pleural pressure variation. That is another fancy thing that you, if you have an esophageal catheter, you can do it, but not, again, everyone doesn't have, and it's mostly based on research purpose. We don't routinely use it. What you can do is simply do a tidal volume challenge test. Fluid responsiveness, again, if the patient is spontaneously breathing and the breathing efforts are significant, so that P.1 is a measure of the initial neural drive of inspiratory pressure. If it is more than 1.5, then the pulse pressure variation has low utility. So simply meaning you don't use it. And wherever the patient is intubated, has an ARDS protocol in situ, you can use a PEEP challenge test to diagnose. Now, two interesting things to use in your routine practice. One is, we know about IVC variation. We do routinely use an IVC everywhere. People are using IVC, but just go beyond that. What can we use else? Can we look at the SVC? And now the question is, SVC, if you want to see, can we see in the routine echo that we do? That is a transthoracic echo that we do. We don't do TEE always. Can we look at the SVC via the transthoracic echo? Can we do the SVC? Can we see the SVC? Second part of the question is, can we do an SVC collapsibility? So the answer is that you can see the SVC by the transthoracic echo. There is a modification that we do, that if you know about subcostal xiphoid view, subxiphoid view, or the subcostal IVC view, you can actually look at it. So you can actually, just give me a second. I'll have an important call to attend. As I was saying, that SVC you can see in a transthoracic echo by the modification of IVC chamber view, I mean subcostal view. You'll have to just tilt your angle so that you get the SVC IVC both, but you cannot see the collapsibility because it's a structure that is beyond your cardiothoracic window. To see that, you need a transesophageal echo, and just for the sake of assessing fluid responsiveness, putting a transesophageal echo is too much. I'll not advocate this method. Rather, you can actually look at the IJV, internal jugular vein, and just understand the concept. If you have cannulated internal jugular veins enough in your life, in especially in CKD patients, AKI patients, you'll get to know that those patients are having volume overload, and these patients are having dilated IJV. Like, they are booming, they are dilated. If you put the needle, immediately it goes in and you can immediately cannulate. It's just as easy as that. What does it indicate? It indicates that they are volume distended. Their variability also reduces. So, if you're by Valsalva maneuver, supposedly if the patient is spontaneously breathing, you ask them for a Valsalva, or if the patient is intubated, then you do a Valsalva by pressing on the PEEP valve, increasing the PEEP, closing the glottis, the kind of maneuver, and see that the variation of the IJV, either you see the surface area or the diameter. If you do the diameter wise, so this is the diameter check. So you can do a cross-sectional diameter by something known as a planimetry. If between inspiration and expiration in a spontaneously breathing patient, and the reverse in mechanically ventilated patient, the increase in the cross-sectional area is more than 17%. Let's forget about 17% as a cutoff. Just remember, if there is an increase in surface area, means the IJV can accumulate more volume, means it is not volume distended. But if it is not getting distended, it is already distended to its maximal capacity, and therefore it is volume repleted or volume overloaded. So IJV variation of cross-sectional diameter, if it is increasing by 17%, it can indicate hypovolemia with a moderate sensitivity and specificity. Not so much accurate, but you can use it. And if you want to use the diameter, you can either use, this is a very common picture that every one of us has seen. You can use the anteroposterior diameter and put an M mode. I have not seen it here, but I mean, you can put an M mode. Simply put the M mode, and you'll get the maximum and the minimum diameter. From there, you can get either IVC distensibility index, the cutoff for which is 18%, or you get an IJV variation index, which is cutoff is 13%. The denominator and the numerator varies. I would ask everyone to just have a look in quickly in the Google and use sometimes in their clinical practice. They will get an idea. Suppose that the patient comes to you extremely shocky patient, you don't have everything in your hand and you don't know properly how to do an echo. You simply do the IJV ultrasound and look at the variation. If your IJV is variable, that means volume depleted. Probably if the IVC is distended and its variation is not there, it is a volume overloaded or there is no chance of giving fluid. Similarly, you can simply do the same thing with femoral vein collapsibility. If you put the probe on the femoral vein in a cross-sectional way, not the longitudinal, cross-sectional way, like you have a circular vein in situ and you put the pulse wave Doppler, you get velocities like this, where some of them are retrograde waves and majority are antigrade. Antigrade means the blood flow is towards the heart, towards the heart. But if the blood flow is from away from the heart, that means it is bad. Veins are meant to flow towards the heart. So if you put the on the femoral vein, everything should be away from the probe. So all the negative waves are normal. Anything positive is abnormal. Now in every patient, some positive waves or some regurgitation is there. But if you have a pulsating vein with retrograde flow of more than 10 centimeters per second or more than one third of the antigrade flow, then you call it abnormal. Just simply put an femoral vein Doppler, femoral vein, look at the femoral vein in patients with CKD and severe tricuspid regurgitation. You will see how much of dilated, how much collapsible it becomes. And more than that, what is more noticeable is that they will look like an artery. You will get confused whether that's an artery that is called pulsating or the vein. And that's why doing this Doppler sampling is very important to differentiate between the two. So femoral vein, IJV, this can be used. Again, I'm not going to the direction that supposedly patient is pregnant or patient has an intra-abdominal pathophysiology. You cannot use femoral vein there. If you have a DVT, you cannot use. So these are all common sense topics, but these are all some, what you say, you can, these are all some replacements of the traditional tests of fluid responsiveness that we use. So till now, we have now discussed about some added points as to yesterday's last class, that what are the important tests that we can determine, based on which we can determine fluid responsiveness, and we can use an IJV ultrasound. There are studies based on subclavian vein ultrasound also. Subclavian vein collapsibility index is also there. The reverse is, the IJV is collapsed during inspiration in a spontaneously breathing patient. The subclavian vein is distended in inspiration. That's the only difference, because it's an intrathoracic structure. So the pressure, and it is getting struck to its wall. There is a surrounding structure as well. So it is basically getting the opposite. So inspiration, it will collapse, and inspiration it will get distended, expiration it will collapse. So that's the basic difference between a subclavian vein along with other ultrasound measures. So coming to the next part, which we have discussed last time also. Yes, LVOTO, I will just go into a detail. So look at this. You look at this. Patient. The scenario: a 65-year-old patient, hypertensive, diabetic with LVH, comes to you, and patient has a sepsis, pneumonia. You have started some antibiotics. You have given vasopressors. You have started norepinephrine. You have given fluids. But your norepinephrine requirement is now escalating very quickly. Now, within half an hour, it has gone from 1 ml of 8/50 to supposedly 10 ml per hour. And you are sure that this is not because of the sepsis that it is worsening. Because septic shock takes some time to worsen. It cannot worsen within half an hour or 45 minutes so quickly. So you have to suspect that this is something else, and you have to use your ultrasound parameters. You do an ultrasound, you see that there is a echo is like normal, except for LVH, there is nothing no. But the IVCs are distended, patient is having bilateral pulmonary edema. What is happening is that this patient is having a dynamic LVOT obstruction. Previously, this was known as an entity known as HOCM, hypertrophic obstructive cardiomyopathy, which only occurred in patients who had an asymmetrical septal hypertrophy and predisposed genetic conditions along with this LVH, and they used to present with hypotension, double apical impulse, asystolic murmur, sudden history of cardiac deaths and all, and obviously arrhythmias. Now we have seen that this is much more common than what we know. Any patient with a hypertrophied heart who is undergoing a dynamic process like a sudden hypotension, blood loss, septic shock, where the systemic vascular resistance reduces, or there is a component of hypovolemia, what you can get is a dynamic obstruction. The name itself suggests that it's dynamic. Probably the patient has not experienced anything like this in previous background, or the patient is not likely to experience future also. But you have to pick it during the time when it happens. So any patient with hypertrophy, I again repeat on the part that it is any patient with LVH can have this. It is not that they will have an asymmetrical septal hypertrophy. What happens is that because of the hypertrophy, and there is a narrowing of the outlet, the LVOTO outlet, and because of, as we know in Bernoulli's theorem, whenever there is an increase in the velocity because of the narrowing of the diameter, there is a reduction in the pressure, and because of that there is hypotension. So the problem here is that the more you give inotropic support, the more beta noradrenaline you push, the more narrowing of the outer diameter it becomes, and the hypotension worsens. And therefore, the treatment of that is giving adequate volume so that this distance between the two touching walls increases, and to increase the afterload by giving a positive vasopressors. I mean pure vasoconstricted agents like a phenylephrine or giving a vasopressin. Therefore, in these cases, it is better to give vasopressin as a single agent. You can give vasopressin as high as 12 units per hour. People have used it and they have seen remarkable results with this use. So the predisposing factors are LVH, patients with diagnosed hypertrophic cardiomyopathy, and coming with hypovolemia, septic shock, or any other acute condition, and has this. How to diagnose? The question is how to diagnose. Look at this waveforms. So if you put your Doppler at the LVOTO and you put the pulse wave Doppler and you trace the tracings, you see that the initial velocities are low and then it increases. This is dagger shaped waveform, and there is a late peaking of the systolic velocities. That means there is an obstruction. That's why the velocities are not increasing initially, it is increasing gradually on the later part. So dagger shaped waveforms along with increased pressure gradient across the aortic valve, not particularly aortic valve, the LVOTO, that is the left ventricular outflow tract, is what tells you that there is an LVOTO process. Any gradient beyond 30, it is very simple to measure. If you just measure the Vmax, the velocity maximum, and that will give you the pressure gradient by the formula 4V square. So if your Vmax is more than, generally by 2.5 to 4 is the range. If it is more than 2.5, they're at risk of LVOT obstruction. More than 4 means 4 into 4 square, that becomes 60 above, definite obstruction. So any gradient more than 30 is significant, more than 50 is definite LVOTO. If that happens, you give some volume, you avoid positive inotropic agents, and you give pure vasoconstrictors like a vasopressin. So this is one entity that is often missed, and it is very common as compared to what we used to think. So do not miss the diagnosis of LVOTO. You should always suspect if you think that your NORAD requirement is drastically increasing. Always use an ultrasound in this practice. Coming to other few topics, VEXAS we have covered last time also. I'll again quickly go through that. Fluid tolerance, intolerance, this we have already discussed. Last class we have discussed about this thing that what is the drawback of giving too much amount of fluids. It can lead to globally increased permeability syndrome. It is a syndrome associated with pressures inside the every compartment, that is the lungs, the abdomen, the muscles, the brain, the eyes, and obviously the soft tissues and the organs like liver, kidneys. So you have a congestive failure of all the organs, and there is an index by which you can calculate. I'm not going to the individual details per se. How to diagnose? You can simply use a lung ultrasound and look at presence of B lines, and you can do the later on part of the part check, that is the VEXAS scoring system. The fluid approach in case of fluid septic shock is we follow the ROSE approach or the SOST approach. The ROSE approach stands for resuscitation, optimization, stabilization, evacuation. SOST is also similarly salvage, optimization, stabilization, and de-resuscitation. What is important is to remember that the later phases of septic shock management is actually de-resuscitation. You have to remove fluids. So you have to keep the patient on negative balance at least twice per week, twice within the first week. In the third phase, there is a stabilization, and after which you have to actually remove the fluids. So this we are not routinely followed, but it should be followed. So this is what is important. Fluid tolerance, intolerance we have discussed in last class. The VEXAS is what I am going to discuss today again. So patient with supposedly a cardiogenic shock, patient has come with cold peripheries. Now the patient is having a transaminitis with a raised urea creatinine, and you want to know whether you have to give fluids or vasopressors. So you use a VEXAS score. VEXAS stands for venous excess ultrasound. Just look at this, that if you have a systemic venous congestion. So if you have a left-sided venous pressure, left-sided venous congestion, or increase in the left-sided pressures, what you get is pulmonary edema. But if you get a systemic venous congestion, if you have a right atrial pressures or right ventricular pressures are elevated, you get systemic venous congestion. And the major veins that we want to see is your IVC, hepatic veins, which are the tributaries of IVC, the portal veins, and the renal veins. So these three veins are sampled for assessing the vexus. So increase in the LA pressures causes pulmonary edema. Increase RA pressures causes systemic congestion like liver edema, kidney edema, and these are all causes of congestive nephropathy, congestive hepatopathy, and so on. It can also cause edema of the brain, every tissue that is around. So you use a curvilinear probe, that is the abdominal ultrasound probe, and you have to put it either on the subxifoid view or on the right mid-axillary line. You have to put across the liver in a longitudinal way, and you have to identify this IVC. Your IVC should be more than 2 centimeters to start off with the VEXA scoring system. If the IVC is less than 2, you generally don't start. Then you have to identify the hepatic veins. The hepatic veins will be much more darker. They lack the proper wall or the hyperechoic wall. And if you put your pulse wave Doppler through the hepatic veins, you will get waveforms like this. Now remember that in the CVP waveforms that we know about, ACVXY. So CVP is the right atrial pressure. If you are measuring the hepatic venous pressure, it will be the exact replica of the CVP waveform with a bit of modification. Supposedly this is the CVP waveform where you have ACVXY waves, and you draw an imaginary line through this between the A and V, and you get a hepatic venous waveform where two upfront waves are there, A and V. You don't have a C wave here, and two down waves are there, which is S and D. So the A wave is the diastolic part, and the S wave is the systolic part. S wave to D wave is the systolic part. S wave particularly. So normally your S is deeper than D. S is larger than D. If your S is smaller than D, that is grade 1 congestion, and if your S is reverse or S is merged with the D, it is severe congestion. So this is how you determine the congestion nature of the hepatic veins. Similarly, if you look at the portal vein and the renal veins, the increased pulsatility is what is abnormal. Now look, the conceptualize this thing. Supposedly you have a heart which is distended, and you have an increased RA pressures. The more distending pressures will get transmitted to the veins. If your veins are at the maximal capacity, the distending pressures will obviously get transmitted, and the pulsatility of the heart will get transmitted to the veins. And therefore, in the portal vein and the renal vein, normally lack of pulsatility is normal. But if you have a pulsating nature of the veins and there, that means the pressure of the heart is directly getting shown there, and that's why the pressure inside those systems are elevated. So if you get a sample of the portal vein, how do you sample the portal vein? Portal vein is sampled similar way to the hepatic vein. And so if you just put your probe across the liver and scan anteriorly, you will see some bright. The difference between a hepatic vein and portal vein is, see, hepatic vein is black without any bright wall, but portal vein is black with some in between hyperechoic shadows and a thickened wall. This is how you identify the portal vein. You put the Doppler, and if your Doppler is looking like this, that is constant flow, there is no variation, this is normal. 30% to 50% is mildly abnormal, and if you see variation which is more than 50%, then it is severely abnormal. This is this one. So see, this is portal vein non-pulsating. If your variation, if your variation is more than 30%, less than 50% is grade 1 congestion, and if it is more than 50% variation, it is grade 2 congestion. If you look at the same sampling, if you do in renal system, how will you do? This is the kidneys with the lobes and the interlobular septa and the interlobar veins and the arteries. So the first thing we have to remember that these are all low velocity systems. Your hepatic veins, portal veins are somewhat higher velocity, but renal vein is a low velocity system. So you have to decrease the sweep speed on your ultrasound first to detect. Otherwise, you will not pick up. Once you have reduced the sweep speed, you can pick out these vessels. The red ones are obviously the arteries, and blue ones are the veins. You don't need to separate them. Just put your ultrasound beam, the curvilinear probe and the beam across any of the vessels, you get two waveforms. One is positive towards the probe, pulsating, which means it is an artery, renal artery, and the venous is the back side, the negative waveform, which is the venous waveform. So this is a normal artery waveform and the venous waveform. Supposedly now there is a congestion. What will happen? So you will have a waveform which is looking like this. So you have fragmentation in the waveform. So continuous waveform, as I said, is normal. You have some fragmentation, some wavy waveforms, which means it is mildly abnormal. And if you see only systolic waves, that means severe abnormal. What happens is if your congestive nephropathy settles in and intracapsular pressure increases, then your renal perfusion only occurs during systole. If you're during diastole, because of the low pressure in the system and increased intracapsular pressure, there is practically no blood flow during diastole, and therefore you get kind of fragmented kind of waveforms. So these biphasic waveforms, grade 1 congestion, grade 2 congestion is monophasic waveforms. This is how you determine. And finally, you have to add up all those things. So you look at three veins. If you have an IVC which is abnormal more than 2 centimeters with any of the mild abnormality, that is hepatic vein of S less than D, or portal vein 30 to 50% abnormality, or renal vein biphasic waveforms, we call it grade 1 congestion or grade 1 Vexus score. If you have any severe abnormality, it is either grade 2 to grade 3. It doesn't matter if you have a severe congestive changes. That means most likely you will going to need diuretics. But there are a lot of pitfalls. That is, first of all, operator dependence and operator experience is important. If you have a cirrhosis of liver with portal hypertension, or patient having a chronic TR, tricuspid regurgitation, you have to know your things or the physiology before you interpret the waveforms. Because supposedly in a patient who is having severe pulmonary hypertension and tricuspid regurgitation, IVC of 22 might be hypovolemic. Because this patient has a chronic TR, their IVC is around 30 to 35 at ease. If you find their IVC at 22, it could be that they are having a relative hypovolemia. It doesn't mean that they are hypovolemic. So you have to always know the background is very important. Whether the patient has cirrhosis, whether the patient has severe pulmonary hypertension with tricuspid regurgitation, how is the heart rhythm, if there is an atrial fibrillation or not. In that cases, you need an ECG tracing before interpreting the hepatic venous waveforms. Otherwise, you're going to get a lot of false interpretation. If you don't know what is S and D, then you can misinterpret S as D and reverse, and you can actually misinterpret. So you need to have an ECG tracing preferably. So, these are the different things that we are able to discuss about Vexus, and few things about cardiogenic shock that last class I have discussed about the cardiogenic shock in very brief period. Just a quick question to whoever is listening. Any queries till now? Anyone wants to ask anything about whatever I've discussed till now?
I have a question.
Yeah, please go ahead.
Cirrhotic patient having mitral regurgitation. Patient
Okay.
was severely hypovolemic and there was abdominal distension, grade 3 abdominal hypertension due to hypoalbuminemia.
Okay.
So we have done central venous line. The IVC was dilated as because of portal hypertension. But when I have done central venous pressure, the CVP was -4, but there was bilateral crepitation due to mitral regurgitation. You got my point. In this
Yes.
case, the ejection fraction was okay, but on my calculation, I have given some fluid. In this situation, it is as because our ICU is an open ICU, it was very crucial to solve this problem, to understand this problem to other multidisciplinary approach. Suppose a hepatologist and the cardiologist and the respiratory and the internal medicine. They are saying that
Okay.
not give fluid. I have said that patient is hypovolemic. We have to give fluid as because there is 4 CVP. What we
Okay.
have done in this class, Vexus will help.
Yes, definitely here Vexus is going to help. See, CVP, as I said, CVP as a static measure is not a good measure for any kind of fluid responsiveness or fluid status. But generally speaking, a low CVP rules out a hypervolemic state, and a very high CVP obviously rules in a hypervolemic state. And it also depends on how you measure, in what cycle you measure. But generally speaking, 4 CVP should not be hypervolemic. However, If you ask me that based on CBP of 4, can we give fluids? I'm not sure. I look at lot of parameters. Like you said, echo was fine. Was how was the capillary refill? You have to look that if your capillary refill is fine, means your end organ perfusion is fine, echo is fine, and
Yes.
patient's lactates can be elevated because liver dysfunction. However, if the BP is holding and there is not much amount of pulse pressure variation, if you have an arterial line, urine output is kind of manageable. I would not probably give fluids. I would rather wait. But if the patient is having, say, capillary refill is prolonged, patient is having a sick looking, urine output is dropping, lungs are dry, echo is fine,
Lungs
CBP.
is overloaded due to mitral regurgitation.
Okay, so
That's the
in
problem.
yeah, so in these cases, if you ask me, I would not rather not give fluids. Problem is that mitral regurgitation. Yes, this is another important thing that is highlighted. If you are doing an echo and your echo is fine, do a color Doppler and rule out a mitral regurgitation or tricuspid regurgitation, because your echo will be normal, but that MR or TR will obviously show up on the color Doppler. If you have a MR of severe MR, moderate to severe MR, it is always advisable to fluid restrict the patient, because otherwise they will have pulmonary edema. Now, what are the pros and cons of fluid in this patient? In this case, supposedly
In
you
this
give,
case, with liver cirrhosis.
yes, that can obviously worsen the pulmonary edema. Rather, I would rather go up on the vasopressors, and I would rather do something for the intra-abdominal hypertension. If there is a significant ascites, I will
Yes. Yes.
drain it so that there is some release of the pressure. IVC kind of is well filled. There is more preload. I will do. I probably use albumin along with the vasopressor to keep the intravascular volume adequate. So I would rather use albumin with vasopressors and paracentesis rather than giving fluids. I always I'm a very very restrictive intensivist in terms of fluids. I only use fluids if the patient is obviously hypovolemic, coming with severe vomiting, dehydration, diarrhea, or shock, blood loss. Otherwise, in a septic patient, I generally don't advocate a huge amount of fluids at all. Only during the resuscitation phase, I give something around between 500 ml to 1 liter maximum. I use my vasopressors to the maximum, because you have to also know something known as a vasopressor challenge test. So if you use vasopressor, the vasopressor also pushes the unstressed volume to stress volume. It pushes your unstressed volume within the capacitance vessels within the main intravascular volume, and therefore it also increases the volume. Just think like that. You're not giving fluids, only vasopressors will also cause the fluid like effect, and that's why using vasopressors earlier and as much as possible in a septic shock is what I prefer and should be preferred. Okay. If you ask me what else, simply look at the blood pressure. If your blood pressure is looking like 160 by 45, or supposedly 100 by 45, means the pulse pressure is 55. So the heart is pumping normally, but your blood pressure is low. Therefore, it is a septic shock. So you need more pressors. If your BP is something like 85 by 30 and your cardiac function is normal, that means it's hypovolemic shock. You need more fluids. So your pulse pressure, the diastolic blood pressure, those are also determinants of what is your underlying etiology. And therefore, to reinstate, you look at the entire picture. What is the patient's presentation, background? Because as I said, that patient with IVC of 25 can be hypovolemic if the patient is having a chronic PH with long-standing hypertension, pulmonary hypertension. Then you patient coming to what kind of pressures is the patient is, what is the background, lung condition, arrhythmias, etc. What that to determine what fluid responsiveness I'm going to use. Is the patient's lungs dry or not? Use an ultrasound. How is the echo? What is the exact pulse pressure reading? What is the capillary?
Arterial blood gas analysis was pH was alkalotic 7.60, and the del ratio was more than 2. It
Okay.
indicating that
So
intravascular volume depletion.
again I'll restate that again there is a change of concepts. So metabolic alkalosis or the contraction alkalosis that we used to think. I mean, suddenly how a patient will develop hypovolemia if the patient is in supposedly not having a severe blood volume loss. So metabolic alkalosis or the contraction alkalosis concept came in from the hypertrophic pyloric stenosis kind of patients, pediatric patients coming with vomiting and then going into a, because the chloride loss there is high metabolic alkalosis. From there it was kind of corroborated. Okay, these patients are volume depleted, but this is not always the case. Not all patients with metabolic alkalosis, urea is more elevated, and creatinine is elevated means their volume depleted. This is an age old concept. These are all, rough estimation. Yes, they can be volume depleted, but always use your ultrasound, IVC, everything combined, then decide on giving up fluids.
Thank you.
Fluids is like drugs, simple as that. We don't give an antibiotic just like that to a patient, right? So
Yes.
similarly, if you want to use a fluid, you have to have a justification. Now,
Thank you.
that's the thing. I mean, you have to use every parameter that is possibly you can use, and then come to a conclusion. And if at all you're giving fluids, if you're unsure, give some small aliquots and see the response. Don't give a bolus of 500 ml, then no response. Again, give 500 ml, no response. So that is something what should not be followed. Okay.
Thank
And
you.
coming to few things about the cardiogenic shock. Last class I've discussed that cardiogenic shock has a definition. Cardiac failure or heart failure is separate. Cardiogenic shock is separate. Cardiogenic shock is defined as having at least blood pressure of SPP less than 90 for 30 minutes or reduction by 30 by mean pressure of less than 60 by at least 30 minutes, or use of vasopressors to maintain the same, along with signs of shock like cold peripheries, altered sensorium, urine output less than 30, that is less than 0.5 mL per kg per hour, and lactate more than 2. And you need to have a hemodynamic criteria as well. If you have a pulmonary arterial catheter, you can use it. One thing to again reinstate, the pulmonary arterial catheter was originally devised to see the left ventricular pressures for all the wrong reasons. If you are using it for a right ventricular pressure, you are absolutely justified in using a PAC. So if you want to monitor CVP, monitor it for the right ventricular failure causes. Don't monitor for the shock or the left ventricular thing. If the patient is having a right ventricular failure, always use a CVP. Your CVP trend will definitely guide you in management of the patient. Okay. Now coming to the same thing. So if your cardiac index has to be less than 2.2, pulmonary capillary pressures again more than 15. But again, I'm saying patient with cardiogenic shock, you have dialyzed the patient or given diuretics, they might not be having increased PCWP. And SVR, see in these categories, what traditionally we used to teach or read is SVR should be high, cardiac output low, increased PCWP. Nowhere in the cardiogenic shock is SVR written as high or the parameter to diagnose. So most of the cardiogenic shock, because of the inflammation, they will also have reduction in the SVR. So cardiogenic shock also has a distributive shock kind of thing. So you have to always don't rely on one single thing. SVR might be lower than normal in these patients as well. And if you want to look at few parameters like power output, it is calculated as cardiac output into MAP by 451. Nobody uses every time, at least for intensivist routine practice, we don't use it. We simply check the echo. We do the cardiac output assessment and ejection fraction. Look at the RV function by means of TAPSE, that is tricuspid annular plane systolic excursion. We can do something known as a tie index. We can do a CVP PCWP ratio. These are all the various measures which we can assess. But these are all, I mean, overview of how to diagnose. And the management inotropic support previously in the class we have discussed. Now today a bit overview on what mechanical circulatory support we can use in cardiogenic shock. So if the cardiogenic shock patient comes to you, first of all, obviously you will go for ABCD approach. You will intubate the patient if required. You will assess the volume status. Not all cardiogenic shock are hypervolemic, mind you. Patient with cardiogenic shock, simply remember, patient has a reduced ejection fraction, but still you are seeing that the blood pressure is low and low urine output. Capillary refill is poor. Patient's lungs are absolutely dry, and if you are well accustomed with echo, you measure the E by E prime. If you can, that is also low, less than 15. One on a general rule, if I'm saying that if the E by E prime, that is a diastolic function measurement, E by E prime is more than 15, means the diastolic compliance is poor. Patient has to have pulmonary edema. If you don't know how to measure E by E prime, simply look at the lungs. If your lungs are dry, E by E prime is low. So dry lungs, poor ejection fraction, low blood pressure, you can simply give a fluid and check. Your CPP is also, if it is low, you can give a fluid and check. There is no harm in giving. Give a 250 ml and check. Don't give 500 ml. So check the volume status, put some lines, and stabilize the patient by means of inotropic support. Assess the cause, whether it is a viral myocarditis, whether it is an acute MI in a middle-aged patient, whether it is MI with cardiogenic shock because of acute myocardial mitral regurgitation from a papillary tendon rupture, or it is aortic dissection. Different etiologies, so different management plans. If you have a viral myocarditis and if you have biventricular failure, what will you do? So if you have a viral myocarditis, I'll give you some picture and you will tell me that what can you do if a patient has myocarditis and biventricular failure. What can you do? What is your option? So the option would be in these cases that you can simply do a VA ECMO, veno arterial ECMO. Patient is having severe myocarditis, you can put a VA ECMO in this patient. Supposedly, the patient is having only right ventricular failure. The LV is kind of fine. What will you do in these cases? So if the patient is having a right ventricular failure, that could be secondary to only hypoxia as well. Just don't rule out hypoxia as a cause. Severe hypoxia will cause cardiogenic shock also. And because they will reduce the coronary perfusion, they will reduce the RV, they will increase the pulmonary pressure, so cause an RV failure. So if you treat the hypoxia, there is a chance that your RV function might improve. And therefore, if the patient is having severe ARDS or severe hypoxia with a cardiogenic shock because of right ventricular failure, you can simply put a VV ECMO and that can improve the cardiac function. So the management is case to case basis and it is quite varied. So as I said again, if the patient is having viral myocarditis, young patient, probably put a V ECMO, that is better. Patient is having a hypoxia induced right ventricular failure, put a VV ECMO. Only RV failure, but hypoxia you have corrected, but still that function is not improving. You have put a VV ECMO. You can convert it to a VAV ECMO. So that is, you have put a veno-venous, two artery venous cannulas are there. You put an extra cannula in the artery, and that is converted to a VV ECMO or VAV ECMO. What else can you do is if isolated RV failure, you can put a RALA ECMO. This is called as a VPA ECMO, veno pulmonary arterial. Because the left axis is normal, you can drain the blood from the IVC or the SVC and you can put it in the pulmonary vein, just bypassing the RV. So these are different options. If you have a severe shock and your output is kind of low, in those cases, as a bridge to transplant or as a proper therapy also, you can use something like artificial heart, tandem heart, Centrimeg, Rotaflow, Impella. These are all different devices which are coaxial pumps which draws in the blood from one ventricle and puts it into the artery. If in case of LV, that is pumps the blood from LV to aorta. If it is an RV to pulmonary artery. There are different specifics of these devices. If you are using for the left heart, left ventricle, it is called as the Impella. There is a RP Impella as well, right ventricular Impella, that is specifically designed for the right heart. So these are all different modalities. I'm not going to the individual details as such, but these are all different modalities that we can consider as a mechanical circulatory syndrome. So cardiogenic shock, these are the different options as I said. One question for you all. Supposedly patient comes with pulmonary embolism. There is a severe RV dysfunction, patient is in shock. How will you approach? And approach means what vasopressor will you use now initially, and then step on how will you approach. Patient comes with shock, you have evaluated, echo showing dilated RARV, RV's dysfunction is there, TAPSE is around 10, IVC is dilated, and patient is having, obviously in shock. So what vasopressor will you start first? First choice kya hoga? What will be the first vasopressor?
Vasopressin?
Very good answer, but the first choice in across all shock is NORAD except for LVOTO. Okay, so even in cardiogenic shock, the first choice is always NORAD. Left ventricular failure, first choice is always NORAD because NORAD is the safest. It has got a lot of benefits and all. I'm not going to the individual details per se. First choice is NORAD. Second choice is vasopressin. Question is why? Why would you prefer vasopressin in a patient with an RV failure? Can it not precipitate the RV failure more? So the thing is, if you look at the vasopressors, the vasopressin, AVP, arginine vasopressin, has a SVR increase effect, pulmonary vaso relaxant effect at a very low dose or probably no effect. So vasopressin does not increase the pulmonary vascular resistance and therefore it has an RV protective effect. So just imagine that you are increasing the systemic vascular pressure resistance and thereby you will push the septum towards its normal position, towards the RV. Because you are increasing the SVR, so the pressure in the LV will increase, it will push the septum towards RV, it will remodel the shape and it will again bring back the interventricular dependence and it will reduce the RV afterload or have no effect. Therefore, vasopressin is preferable in these cases. You can also use epinephrine, single agent, because epinephrine has got a vasodilatory action also. It has got positive inotrope, some vasodilatory action. Therefore, epinephrine also can be used as a solo agent. Different school of thought, different people use different things. But if the patient has an isolated RV dysfunction, NORAD vaso works very well. NORAD ADR also can be tried, but definitely you should not try something like phenylephrine or metanaminol. These kind of things are not to be tried. Okay, and if the patient's blood pressure is stabilizing, no hypotension, you can also give a trial of dobutamine, or if the patient is beta block previously, then you can try milrinone as well. But case to case basis, there are a lot of drawbacks if they're using it. If the patient is not responding to that, then what can you do? In pulmonary embolism, patient is shock, acutely sick patient, diagnose pulmonary embolism. Other than managing, you can put a VA ECMO, as I was discussing. So if the patient is having a significant hypoxia that is causing the failure, you can put a VV ECMO and wait for the result. If the VV ECMO is not working, probably you put another arterial canal, convert to VV heavy ECMO. And I was discussing isolated RV failure. You can put an Impel RP or VPA ECMO, different modalities. These are a bit on the advanced kind of critical care, which I am also kind of learning on my ways. But these are all the different options that you should definitely know about. So I guess that's it. I mean, these are the things I wanted to discuss. Let me have a checklist. I had made a checklist of what things I need to discuss. Scenarios, tolerance, vexus, CRT, ultrasound based cardiogenic shock scenarios. Okay. Anything you want to know? Anything? Very basic question. If the any patient in ICU and what one single test, if it is normal, will tell you that probably you are on the right track. You don't need more fluids. You can go up on the pressures, but you generally don't need fluids. What only test? It is not a lab test. It is a clinical sign. What clinical sign we should always check in a patient who is in shock? Last question of the day. In sepsis, cardiogenic shock, anywhere.
Urine output.
Urine output again is a dynamic parameter. Anything better than that? See, urine. What kidneys are very smart. Whenever if you read about renal pathophysiology and the autoregulation, the moment your MAP reduces to less than 60 or even 50, the GFR reduces, because the kidneys sense, okay, my body is now undergoing a stress. Therefore, I will preserve the urine and I will not let the urine go out. I'll preserve some volume. So that is actually a kind of smart move. So reduce urine output is kind of a very, very static parameter. It is not definitely not a marker of either hyperperfusion, hypoperfusion, anything. Anything else that we have to check routinely? There is a trial, huge trial, famous trial, one of the most famous trial ever in critical care based on this test. So that is a capillary refill time, simple capillary refill. Okay, so you take the patient's fingers and you press it for 5 to 10 seconds and you look at the capillary refill. If it is more than 3 seconds, it's definitely abnormal. If the capillary refill is normal, patient has a cool normal peripheries, normal capillary refill, rest assured that what you are doing is right. Your fluid status most likely is normal and your microcirculation is also adequately adequate. So whatever you're doing at the macro level, it is going to affect your micro level. If your lactates are high, probably you can give fluids. If you decide upon the other parameters, it is going to help your microcirculation. But if your capillary refill is prolonged, it just indicates that the patient has an inadequate perfusion at the microcirculation level. So if you have a capillary refill which is prolonged, raised lactates, patient is going to die or bad condition. If you have a capillary refill which is normal, still raised lactates, you are actually in the good path. You are not so, the patient is not so sick. Meaning to say, capillary refill as per the Andromeda shock trial is a very, very important test to be done in every patient. Every patient you should do. And as a marker of fluid responsiveness, normalization of capillary refill was better as compared to traditional lactate guided fluid measurement and had lesser amount of positive fluid balance. That's what is sepsis 2021 guideline tells us. And therefore, a capillary refill guided fluid resuscitation is much better than a lactate guided fluid resuscitation. And Then there are a lot of studies has been done after that, which has shown that as per the Bayesian meta-analysis, there is actually a mortality benefit with using a capillary refill guided method. So always use your capillary refill. And if your patient is coming to you, patient is supposedly tachypneic, blood pressure of 120/60, but your capillary refill is bad, means the patient is going to collapse anytime. Your microcirculation is not good. So always check capillary refill in patients. I think that's it. Any questions, any queries that you can raise right now? As I said, today's class was kind of a recap of previous class, but because previous class was humongous, with so many huge topics to be covered, I took around 2 hours class. Still, I wanted to discuss some intimate, like important points, conceptual things today. Any questions from your side? I guess that's it. I think chat one. Okay. Okay. I guess.
Also, ধন্যবাদ দাদা আপনাকে ক্লাসের জন্য এক্সেলেন্ট হয়েছে ক্লাসটা
Okay. Okay. Thank you. Okay. I think that's it for the day. Thank you, organizers. I'll then sign off.